right, so we'll get started. Hi, everyone. Welcome back. So today we're going to talk about endometriosis and fertility because that is one of the main questions that come up every single time we see an endometriosis patient. So I'm Kathy Huang again. I'm just going to let everyone introduce themselves. I'll just go according to the order you guys show up my screen. Francesca.
Hi, everyone. I'm Francesca Barrett. I'm a MD MBA. I'm a third year NYU resident in OBGYN and planning on pursuing infertility fellowship.
Dr. Licciardi.
Hi, my name is Fred Licciardi. I am an infertility specialist. I've been at NYU since 1992. We built a large infertility program here, and we have in vitro fertilization. We have referrals to people like Dr. Huang and other people for surgery. And the center is just fantastic. So it's a really good place for patients to get a start.
Lara, returning panelist.
Thanks, Kathy. I'm Lara Rosenthal. I'm an acupuncturist and a Chinese herbologist, and I specialize in women's health and fertility. I've been working closely with the Fertility Center since 2009, and actually, started my practice probably in 2005 originally. And I've also been working closely with the Endometriosis Center for the last year or two. And I'm just very happy to be here. Thanks, Kathy, for inviting me.
Of course. So we have a whole group of people because, again, we always want to come at it with a multidisciplinary perspective. We really want to make sure that the different concerns from the patients are addressed in a way that's holistic. I would just say that as I was saying right before we started this, I was listening to a podcast by Glenn Doyle, who is like my favorite person, favorite celebrity, and Gabrielle Union talking about her fertility journey. And it was so raw. And she was talking about how every month when her period comes, it felt like a little death. And she was talking about the fact that she just felt like she was doing something wrong, that she could not get pregnant. And is it something, and she was talking about even with the surrogate that she felt like she was deeply flawed, but for some reason she could not give her husband, her family, the child that she so desperately wants to give them. And I think it was just a really touching conversation because it was just so honest. And I was saying, I wish that more women would talk about this because so that they don't have to feel they are dealing with this alone, because it really is impacting a lot of women, especially in New York City. There was a whole New York Times article on this about how people are delaying childbearing, especially for female physicians. So, case in point, Kathy's turning 42. I'm talking about myself as a third person next month, and clearly I don't have a child. So, it is a struggle when you have so many things on your plate that, you are expected. There's so many expectations and you somehow just feel, I'll say, I somehow feel deeply flawed in so many different ways because I can't seem to meet all the different needs that are coming at me. And I at least want to be honest about that with everyone. And hopefully that is a way for everybody else to talk about their struggles. Okay, I'm going to stop on my own sob story here. I've known Dr. Licciardi since I was a medical student. So I was hoping Dr. Licciardi can talk a little bit about his experience dealing with patients with endometriosis, the fertility aspect, and maybe some of the most common myths that he may want to dispel and tell us about and share with us.
Sure. Thank you very much, Kathy. Thank you. So, endometriosis, as most of you know, is a huge spectrum. There are people who have a very small amount of endometriosis, yet it causes a lot of pain and discomfort. And there are people who have quite a bit of endometriosis, and maybe they don't feel that sick either. But when it comes to fertility, we mostly deal with the more severe cases because those are the endometriosis. So let's take care of a couple myths first. Does endometriosis interfere with ovulation? The answer is no. Does endometriosis interfere with fertilization? Probably doesn't. Does it interfere with implantation? Because there's all these theories around that endometriosis is this very inflammatory condition, which it is, and it creates chemicals that might interfere with fertilization or embryo implantation, et cetera, or cause miscarriage. And it just doesn't appear that there's data to show that. There is data to show that if you do in vitro fertilization and you have endometriosis, your pregnancy rate might be a little bit lower than if you don't. But we believe that's primarily due to the fact that a lot of women with endometriosis make fewer eggs. You know, we talked about this chronic inflammation. This chronic inflammation it's a horrible way to say it, but it can really attack the ovaries and destroy some eggs that are present over long periods of time. And so if a woman goes to do in vitro, you know, a lot of people think that in vitro just solves everything. Oh, I have a problem. I have no eggs, therefore I'll do in vitro, or I have severe endometriosis. But it doesn't really work that way. We still need the body to cooperate. We still need the body to make a lot of it, as many eggs as we can get. And so that's kind of the patient that we see really who needs in vitro. If endometriosis spreads to the point where it's blocking a fallopian tube, that's a different, then for infertility is an issue right away, of course. But if there's just some pain, maybe a small cyst, not any tubal blockage, good ovarian function, women with endometriosis actually can do quite well, even without in vitro fertilization.
So I have a question. Also, if the audience have any questions, feel free to put it in the chat box, and I'll continue to monitor that to ask the panelists. The question I had was about, I've always had this question previously, is AMH, the ovarian reserve hormone, lower in patients with endometriosis without endometrioma?
So AMH is if there's an endometrioma, meaning a cyst, if you just have some implants that we call them, right? A little bit around your ovary, a little bit around your tube inside your pelvis, your uterosacral ligaments, that kind of stuff. I haven't found that AMH is any different. I have found that actually AMH, and you may have discussed this before, can actually increase when there's an endometrioma, when there's a fibroid. That is very deceiving for patients. They come in, they say, oh, you know I know I have this chronic endo, but my AMH is 3. And then do a scan, and all I see is a couple big endometriomas and no resting follicles. That's not uncommon. Same thing with adenomyosis. Adenomyosis can actually bump up your AMH a little bit also. So can fibroids, but more so, I've seen it more in endometriosis and adenomyosis.
I had no idea. So this has been really helpful for me. Okay. So Lara, I think I want to also put that to you and see from your perspective. I mean, obviously I just do surgery, so I'm going to just cut out endometriosis, but I want to understand from your perspective, how does the holistic Chinese medicine aspect, how does that help out patients who are struggling with fertility and trying to conceive?
Well, okay. I'd say the question around endometriosis and fertility is actually a very big question, because there are going to be women, like some of the women that I see in my practice are in their early 20s and they've been diagnosed with endometriosis, but they're not anywhere near ready to start embarking on trying to create a family. And so they may have like a 10 or more year period where there's like this seed planted in their brain, like they have endometriosis, and I know that causes fertility issues. But what do you do about that? So there's sort of that population. And then there's the population that's actively trying to get pregnant. And I think, so there's sort of like a long-term view of this and a shorter-term view of this for people who are actively trying. The way Chinese medicine looks at endometriosis is we talk about things as having a branch and a root. So, you know, obviously historically there were no laparoscopies. We couldn't go into the body and like see exactly what was happening. So Chinese medicine has always diagnosed this based on symptoms, which also, by the way, leaves out a lot because there is silent endometriosis. There are women that have like pretty significant endometriosis that are not really symptomatic. So the population that, you know, we're thinking of for the most part in Chinese medicine is the part that the people who are symptomatic. And so the branch of the problem, meaning like the manifestation, is going to be pain, or it could be, very clotty periods, or but mainly pain, and potentially fertility issues. Then they're sort of taking a step back where, we start thinking, okay, well, what's causing that pain? And I also just want to mention that when we practice Chinese medicine, we have a whole separate diagnostic system. So when somebody comes in with a diagnosis of endometriosis, we also have to take a step back and re-diagnose from within the Chinese medicine paradigm. And when we do that, what we're mostly finding is that like the most common sort of root level causes for endometriosis have to do with sort of weak digestion, what in Chinese medicine lingo, that would be like spleen qi deficiency, or some sort of hormonal issue, meaning that like there's an imbalance between say estrogen and progesterone. Like there's, it's an estrogen dependent issue. And the estrogen is not counterbalanced properly by the progesterone. And the language that we would use in Chinese medicine is this is an imbalance of kidney yin and kidney yang. And mainly it's a kidney yang deficiency. So things like either women are they're not producing enough progesterone, they're not absorbing it well in some way. Vitamin D is also considered like a hormone, a yang hormone in Chinese medicine. And so there may be some issues with absorption of vitamin D. And so, over the longer period of time, we're sort of looking to regulate digestion and help women's hormonal balance. That's the short story. And getting back to the root issues, we look at pain as blood stasis, pain in any kind of like conglomeration of tissue that shouldn't be here, like an endometriosis or adhesion. That's all considered blood stasis in Chinese medicine. And there are separate strategies for addressing blood stasis, we'd call that digestive weakness and that hormonal weakness, all have separate strategies in terms of acupuncture and Chinese herbs, and also nutrition. And there's also this other element of what we'd call heat or inflammation. And so those are the basic things that we're thinking about. Does that make sense to you guys? Do you follow what I'm talking about?
Yeah, it sounds, I may be wrong, so I'm just going to rephrase and then you can correct me, that if someone shows up with endometriosis with different sort of issues, either stasis or an imbalance of hormone, the way you approach it obviously is going to be different. And then
yes,
you tailor that treatment to however you personalize treatment, obviously, right? And then we obviously all work very closely together, all three of us, in different aspects to optimize the patient's outcome. So, I often send patients to you to even get pre-op optimization. Like, what is the condition of the patient? Because I think often we forget about that, right? I would say, even me, when I had surgery, you were like, are you going to take a day off before surgery? I'm like, what? That sounds insane. I'm going to go have surgery and then I'll come back to work the next day.
Squeeze it in my schedule between.
Yeah, I'll try to figure out like how I can do this on a day that does not impact my life. And I'll leave like Thursday night for my surgery on Friday. And then, this is all going to be great. And that's really suboptimal, right? We do talk a lot about post-op care, but our post-op care is much more of a, thinking about what we need to do after surgery without thinking about the entire process of how can we set you up for success. Like, what does the planning process look like? How do we think about it the second you actually schedule the surgery? What are the things that we can do to, yes, I'm going to walk out of that OR and I'm going to be fine, but how do you then decrease the time that I need to spend recovering? How do we optimize that? And so that we can get the patient back to their normal daily activities as soon as possible without leaving all these, undealt with situations.
Yeah.
And it's coordination, right? We talk about surgery first or IVF first. What does the patient want? There's so much that goes on in this conversation when we try to coordinate what is the best care for the patient. But I also want to jump to Francesca to really see what's her perspective. So Francesca is like, I probably shouldn't say this, but one of my favorite residents.
Oh.
She's really fantastic, and we worked in the OR together quite a bit, and she's a really smart and caring human being. So she is applying for REI, so she has a keen interest in fertility, and she's seen. So Francesca, what are your perspectives? What are the things that you feel like?
Can you all hear me? I just want to make sure because my computer is freezing a little bit. Can you hear me, Dr. Huang?
Yes.
Okay, perfect. So a few thoughts. The first is I'm just really inspired to even be on this panel and to be around patients and just know how much of a balance there is between desiring fertility and trying to manage your pain. And at times it can feel like they're in opposition to themselves, especially when so much of endometriosis treatment, when you're not fertility directed, can feel like it's taking a few steps back. So that's kind of the first thing I wanted to say. The second is that I'm always thinking about general like healthcare systems and where healthcare is moving forward. And I think even just today, there was a endometriosis caucus by one of the representatives, I think the House representative on endometriosis, and trying to gather more research. And there have been a lot of recent articles about how the market size and how people are investing more into research within the field. So it gives me a lot of excitement that even though more research is needed, that more is coming in the future as well to try and help our patients. And the last thing that kind of gets me very excited is fertility preservation as a way to kind of think about if you are waiting several years before you're ready for fertility today, that endometriosis patients do overall well with fertility preservation, which is egg freezing, which is now a more hot topic that you've probably seen in the news. And there have been some recent.
Oh, we lost Francesca. I think we lost her. But I really wanted to hear more about the caucus and what we can do to help the patients. Well, why don't we jump into egg freezing in the meantime? Dr. Licciardi, tell us what you think.
Egg freezing has, it's really historical. What's going on in egg freezing? It took a long time for us to get the techniques down. Then it was labeled experimental. Now,
hi, I'm so sorry. I think my computer just
no problem
bugged out, so I'm not sure where you lost me. So, Dr. Licciardi, do you mind telling me where I was before my computer?
Yes, so we were very interested in hearing about this legislative process.
Oh, yeah. Oh, great. Okay, so there was actually a House endometriosis caucus today that was gathering around by a congressman. I believe she's from, I need to look, in Atlanta, a Democrat who personally had suffered from endometriosis, had gone through multiple surgeries, and had made it her mission to try and kind of gather more awareness around endometriosis, help with investments within and things like that. So I think that there's a legislative policy aspect that is really kind of exciting around endometriosis, that while we have a lot of options for women within fertility, for people who have endometriosis, that there's still a bright, wide horizon ahead from a legislative purpose, from a cost purpose. And then the last thing I was saying that I think I got caught up with is even within the movement of this like hot trend of egg freezing, that women with endometriosis actually are really good candidates for egg freezing if you're someone who isn't necessarily thinking about fertility today, given the fact that with AMHs, with endometriomas, and there are some recent studies that even suggest that before having certain surgical excisions, it may make sense or it could be reasonable to consider egg freezing. And so I think that there are options available to women who are concerned about fertility, that there's reality within the reason why we're having this panel today. But I think that, in the next 5, 10, 15 years, there's political interest, there's business interest and investments. There's a lot of money going into femtech. And I think that there are progressive options in research from the medical field to try and help women think about their fertility. There's more interest in trying to open up the conversations, as Dr. Huang was saying, on that topic. And so I'm just really excited to be a part of the field and moving forward in it.
Well, this ties in nicely into Dr. Licciardi was gonna give us a little more information on egg freezing and how should we be approaching it with endometriosis patients? What is the statistic? What does that look like?
Sure. So, for I think most people on the call are aware that fertility changes at about 34, 33, 35 years of age, and starts decreasing. The number of eggs decrease and the quality of the eggs decrease. So therefore, quote unquote, preserving fertility for some people is something that they desire and is available. With endometriosis, that might shift. The age might shift to a younger age, because if there is inflammation, if there's a lot of cysts, if there's diminished egg presence, then that's only going to get worse via endometriosis and with aging at the same time. So someone with endometriosis, even at a younger age, might be very good candidates for freezing their eggs. Just keep in mind, I touched on this before, the egg yield from an egg freeze cycle may not be optimal due to the presence of endometriosis. So we would just have to see. I always like to make it clear, egg freezing is never a guarantee. And it can work out well. We do a lot of egg freezing. Egg freezing works very well, but it's not perfect. Women sometimes have to do multiple tries. Certainly there's cost involved with that effort. But just because you have endometriosis, if you were just first given a diagnosis of endometriosis, it's not the end of the world. We can examine you, see what's going on. Maybe you're a candidate for freezing your eggs, surgery. There's so many, it's great. There's so many facets here on the call that we can really take a multi-system approach to helping you with your fertility.
So Lara, is there any herbs or acupuncture specifically to improve ovarian reserve? I actually don't know. I have no idea what the answer is.
Well, that's a great question. Okay, here's what I don't think there's, in terms of like herbs that specifically increase AMH, I don't know of any studies about this. But what I will say is that I think there's a lot of things that we do that can, how can I say, like weigh on our reproductive system and actually suppress AMH. So one thing that like we'll do with patients who come in, and this could be prior to an IVF cycle or just trying to get pregnant naturally, or even an egg freeze cycle, is what I loosely call like the cleanup, is really going through and trying to like optimize their nutrition, make sure they're eating in a way that actually like works for their body and supports them, nutritionally, and is in line with like their Chinese medicine patterns, doesn't exacerbate inflammation, is sort of more of an anti-inflammatory diet. So, I'll often have people consider doing an elimination diet to sort of remove things that can potentially be food intolerances that could potentially be increasing inflammation in their system, trying to eat organic foods. This is part of it. And then also doing regular acupuncture to really help improve blood flow into the reproductive system, and also just help rebalance the body. And one thing I didn't mention earlier that I wanted to mention is that Chinese medicine, unlike Western medicine, never separated the mind and the body. The mind and the body have always been one cohesive whole. And so this is something that we'll also talk to patients about, because, and there's actually there was a really interesting study that I know, Kathy, you know about the chances of women having endometriosis who've experienced various forms of childhood abuse. And so there are a lot of people walking around that have had, some form of like significant experiences in their early lives that have set up their nervous system in a certain way and can be a source of like really long-term chronic stress. And it seems that, let's see, women who had severe chronic abuse were 79% had a 79% increased risk of endometriosis than women who had not had those experiences. So these, and I don't want, it's a tricky thing to talk about the mind-body connection with endometriosis, but I do think there is something there. And so also, using, directing patients and talking about things that have to do with the way the body holds, the way the nervous system like holds chronic stress or trauma. is also important. And so in terms of people who are trying to, actively get pregnant or freeze eggs or prepare for an IVF cycle, calming the nervous system can also play a really significant role.
Yeah, and there are different ways that you can help women achieve that, to calm the nervous system, right? So I'm just going to ask for the patients who are on this call, are there, obviously they can't all see you, so are there very broad guidelines of things that they should definitely not eat, or things that they can definitely eat? I'm obviously oversimplifying this, but if there are some general guidelines that they can follow and then seek further nuance in terms of what are the things that are good for them. Like I've always just the general thing I've always said to patients is just, less processed food. But and that's really all I say. I think eat things that fuels you. But I'm sure you can be more specific than I can be about this.
I think this is really fundamental. Honestly, I think there should be a class on this in like every fourth grade class that we should learn about fundamental nutrition. Anyway, things that are generally inflammatory, sugar. So all these soft drinks, even fruit juices, dried fruit, these are all concentrated sources of sugar, cookies, cakes, all that stuff. Not so great. It doesn't mean you have to eliminate it completely, but just small amounts. So that's the number one inflammatory thing. Alcohol is inflammatory. There's certain foods that are, fatty red meats. I think there's some controversy about this, but certainly conventionally raised red meats and fats and things like processed deli meats or things that have a lot of nitrates like bacon and salami are generally inflammatory. So having a lot of those things in anyone's diet is not going to be great. I think for women with endometriosis, I have found that there's so whenever I always ask, what have you tried nutritionally? And if they have, almost all of them say, I don't like red meat, or it doesn't agree with me. There's a huge percentage. And I think that is significant. There's something about that for some reason with endometriosis, it just doesn't seem to work very well with that population. And foods that tend to be anti-inflammatory, most vegetables. There's a class of vegetables called the cruciferous vegetables, which includes things like broccoli and cauliflower, sort of some of the harder vegetables, cabbage, Brussels sprouts. And those contain compounds that actually aid in estrogen metabolism and send estrogen down sort of a more safe pathway. So that's a nice thing to include in one's diet. And in general, I tell people, think about having half your plate be vegetables of some sort. And if you're able to, try to make them as organic as you can, because part of the reason pesticides are effective is that they're endocrine disruptors. They disrupt the reproductive cycle of insects. That's why they work. And so trying to limit that, I think, is helpful. Those are the basics. There's some other foods that are common, people have common intolerances to, like dairy and gluten. I think it's worth at some point just, trying a proper elimination diet and doing it at a time when you can really do it as a clean experiment for yourself, where other aspects of life are relatively stable, and there's all sorts of stuff online about how to do an elimination diet, but it's you basically have a period of time where you don't eat certain foods, and then you reintroduce them very systematically, and you see if you have a reaction. And it's actually the gold standard, because there's a lot we don't know about exactly how we process, how we digest certain foods and individual differences. So it's not like there's just a blood test you could do that will identify all your things that agree with you and don't agree with you, and the foods that are your friend and that aren't your friend.
Yeah.
So those are some of the basics.
Great. I just want
good fertility foods. I'll just say a few other things. Certain fish tend to be good. Things like wild salmon and sardines are high in omega-3s. That's helpful. Trying to think of what else. Nuts and seeds, if you tolerate them well, tend to be good. So anyway, avocado, good fats. Things like avocado is a good fat. Olive oil, rather than some of the processed oils or things like margarine, or we're getting way outside of Chinese medicine, but those are some of the simple things I tell
I think
patients.
these are definitely questions that people have all the time. Omega-3 seems to be good for like a million different things, like brain health, mood disorder.
Yes.
Certainly sounds like it's also, again, what you were mentioning before is that the body and the mind is just one system, right? It's not like I can detach my brain from the rest of my body and somehow it doesn't all interact, because hormonally, I mean, at the very least, the hormones circulate throughout the body. So it does very much, even in the Western science way of thinking about it, they all interconnected. So I just want to mention to the people on this webinar again, that feel free to ask any questions you have. I'm going to jump to the conversation that I think we were about to have about one, how we optimize patients for surgery, how we optimize patients for endometriosis, not endometriosis, for IVF, fertility treatment, but also the interplay between fertility treatment and surgery. And oftentimes I think we go back and forth trying to figure out, I don't think we have a set answer. I think we often try to understand what is it that the patient is trying to achieve. If it's mainly pain, then I can take care of it, right? So I'm really only good at cutting out stuff. I can't address anything else. But with the collaboration with our fertility specialists, I think there is a real effort that can be 1 + 1 = 5. Or, between the fertility, the cycles, and Lara and I, the three of us combined together, hopefully it's not 1 + 1 + 1 = 3. Hopefully when we coordinate our efforts, the results will be magnified, so that it's a logarithmic increase and not just like a linear increase. So that's sort of just where I want to set the stage. And Dr. Licciardi, how do we usually handle these patients? What are the advice you have for patients? Because I think often they come and say, hey, should I do IVF first or should I do surgery first? Like, how do you handle those?
I think it depends on the patient and how we're going to do it. Most people can actually do either first. If they come to me as a fertility patient and they have a lifestyle problem with the amount of pain that they have, they're missing work, it's affecting their relationship, whatever it is, I say, you got to fix this before we even talk about your fertility. And so that's really important. If someone comes in and they have a 2 centimeter, 3 centimeter endometrioma, they feel fine, and I can see other eggs around them, then it's really surgery, if they're not that symptomatic, probably isn't the first thing that they should consider. Where it really becomes dicey is when patients have low reserve, large cysts, and we're trying to determine what's going to help their fertility most, if we do the surgery first, or we freeze their eggs, or do in vitro first. And that also just depends on case by case. The key is, thank you, Kathy. You need to have a surgeon that's very mindful, very fertility mindful. And because we know that when endometriomas or endometriosis cysts are removed, that some eggs can come out with that cyst, even under very careful circumstances. So the more careful the surgeon is, the more likely that he or she is to preserve the good ovarian tissue that's present. So if we have someone, I'm sorry for the audience, maybe you're not familiar with the numbers and the terms, but if we have let's say a size of a lemon, let's do it that way, endometriosis, we may be worried that we're not going to get as many eggs as we'd like when we do in vitro first. And we might send that patient for surgery first, keeping in mind it's tricky because we don't at the same time want to reduce the fertility by taking out that cyst, which can definitely happen if you don't go to the right surgeon. So these are very common discussions that we have to have. And sometimes it's 50-50. And we have to just let the patient know, and then the patients can decide. I mean, we want to guide them, we want to help them, but sometimes it really comes down to their preference. And as long as we're all communicating, I mean, that's really what it's about. That's fine.
Yeah, I mean, it is tough, right? Sometimes you say there's endometrioma, the chocolate cyst that's in the ovary, and we know that the inflammation from that can perhaps lead to a negative quality on the eggs. So thought would be, do you take the patient to surgery first? But however, during the process of surgery, I mean, I cannot not touch the ovary. That's just not physically possible since the mass is in the ovary. So by cutting into the ovary, I inevitably will damage some ovarian tissue. So sometimes there is no clear answer. And that's why we do, at least in our practice, and we're trying to standardize it in all of our mixed surgeons, is that we'll get an AMH. Again, now I'm hearing that may be falsely elevated, but it's at least some measure of baseline of where is this patient at with their fertility. Of course, the age plays into it as well. So just to get a little more information than, just how old you are. And even though I know age is still the most important indicator for successful pregnancy, so we try to get a little more information. Again, we work together as a group to figure out what is the best path for this specific patient. And I'm certain that we don't always have an answer like on the front end, because with the IVF, sometimes because you have so much hormone in your body, it could make the endometriosis worse. And we definitely have seen lesions possibly in the path of the retrieval. I mean, again, this is to be expected, right? This is not surprising to anyone, but it does. But then I also tell them, but if you get pregnant during pregnancy, endometriosis essentially doesn't exist. So we may never have to operate. We only want to do the surgeries that are absolutely necessary. So we're not trying to grab everybody to the OR. That is not our goal. We want to only do surgery that's meaningful, that's going to be improving your symptoms or improving outcome in one way or another. So sometimes patients are asymptomatic, no symptoms, no pain, and only cannot conceive. In those scenarios, even if they have very bad endometriosis, I mean, our answer is not to operate. If you don't have any symptoms and you just want to get pregnant, I think you should just go IVF first. I mean, that's just my perspective, and that's how we try to tailor the plans according to the patient's wishes. What is their most desired outcome? Francesca, any thoughts on that?
The only other thing I was going to add, which may be posed as a question to Dr. Licciardi, but in order to kind of also optimize IVF, we can give medications like hormonal medications like GnRH, which can help try and decrease that environment that we were talking about earlier, where there's so much inflammation and everything, to try and improve IVF outcomes. And just kind of wanted to bring that up as well, that there are ways that they kind of all pair together as well, where it's not necessarily one versus the other, but how like the whole team works together and can consider ways to kind of put endometriosis at bay. But I would also defer to Dr. Licciardi, who's more of the expert.
Well, thank you, Francesca. That was really well said. I do think it's a little debatable on if endometriosis is going to, if we have to do surgery to improve embryo quality, if we have to improve egg quality. I don't kind of follow that tenet. I'm fine getting eggs with someone who's got endometriosis there, because in the lab, we're going to wash them. We're going to, fertilize them. Everything's controlled environment. So I personally don't worry about that too much. As far as trying to match your AMH to the ovarian reserve in someone with endometriosis, I try to just correlate that also with the resting follicle count. I'll do all that, and I don't know if you have access. I don't know if you're radiologists. If you tell them, hey, can you also do a resting follicle count? Then you'll start seeing some sort of divergence. You'll see some people with endometriomas that really have few follicles, and the opposite also. So that, to me, that's a good way to ferret that out.
So I'm just going to phrase it back to you again to make sure that I understand. It is that if you, let's say there are two women who came in who are both 38, I'm making this up, obviously, 38 AMH of 2. So and without seeing the antral follicle count, then I would not know if the 2 is falsely elevated or 2 is a true reflection of the ovarian reserve. So you're saying, in addition to the AMH that we are doing, getting either ultrasound to get an idea of, if they're already seeing you guys, then we don't need to get an ultrasound because you guys already have that information. I can just get it from you. But if the patient actually does not already have an ultrasound, and is very interested in this conversation, then they definitely need to get an antral follicle count in addition to the AMH if they're afflicted with endometriosis, which gives us a better picture. Would that be accurate?
Yeah, and MRI isn't the best for resting follicle count, but you can get a sneak peek sometimes of follicles when you do the MRI. You can see little, if the AMH comes back decent and you got an MRI anyway, and you just see that there's, you know, a fair number of follicles there. I think that you feel more comfortable that the AMH is real.
Got it.
Nicer to have a count, but if you get an MRI and all you see is that circumscribed, the only thing in that ovary is a cyst,
there is probably a falsely elevated AMH that we're falsely reassured by the elevated number, but in fact, their ovarian reserve may not be great. So I guess also then how do we tie in, I'm going to go back to you again, Lara, how do we really complete this whole process by pulling all the different levers, right? I think what I do and what Dr. Licciardi does is perhaps a bit more invasive. I mean, certainly mine's the most invasive. I'm cutting into the human body. So how do we then optimize all the different conditions surrounding this, you know, huge event? And the fertility process, if you're getting IVF, is, as I was saying right before we signed on, is emotionally, physically, and financially taxing, right? I mean, we all wish that we can just conceive naturally, but if that is not a possibility going after that route, I think that we want to make sure that if we're if we're pursuing IVF or we're pursuing surgery, we should be doing everything else to make sure that these interventions will have the best chance of succeeding, you know, such as being at the NYU IVF Center, which is a fantastic world-class place to have your IVF cycle if you were going to pursue that route. But even then, obviously, you need to have a reputable surgeon, a reputable physician to help you treat this. But how do we then even more, how do we optimize the chances of succeeding with either surgery or IVF? How can you help us do that?
Well, I think this goes back to how to optimize fertility in general. But I think it's especially true with patients with endometriosis. And I mean, I'd say, like, in a perfect world, what I would love to be able to do to work with patients who are going to be starting an IVF cycle is see them, like, get them started on a process like 2 to 3 months ahead of time so that they can really work on optimizing their overall health with specific regard to their reproductive health. But you know, the reproductive system doesn't live in a vacuum. It lives in a whole body. And I think sometimes we can get into this zone of thinking that, oh, it's all about this. But, like, you know, sometimes I end up talking to patients about really fundamental stuff. Like, you know, I mentioned nutrition, or they're not sleeping, or they're, like, you know, super stressed out about something, or that, you know, maybe they just need to have a conversation that could potentially resolve that thing. Or but I think, you know, this is sort of what happens when someone comes in for acupuncture, is that we talk to them about, like, these are the patterns that we're seeing, that, you know, there's, you know, what we would call chi stagnation, like, you're really stressed out. What's stressing you out? How can we strategize about, like, calming that down? You know, your digestion's a little off. How can we support that? You know, it might be that they need to eat, like, more, you know, they're eating all, like, freezing cold processed foods, and we want them to have, like, real, like, whole foods, hot foods, and not, like, you know, these things are considered more digestible in Chinese medicine. So, you know, taking that time, and though all these interventions take time, like doing acupuncture, really improving blood flow, improving, you know, helping to, like, clear some of the inflammatory cytokines. It's a little bit of a process. So, but the thing is, people know when they're making progress because they feel better. Like, they start feeling noticeably better. And so it's not like it's this mysterious thing. Like, you can tell, you know, when you, and you know, that's really where peak fertility happens, whatever whether there's endometriosis or not, is when, you know, your whole system is functioning better as a whole. And I think especially because endometriosis does seem to have there's some theory that it has an autoimmune component, you know, again, just like when things are more balanced overall, a lot of those things just become quieter. And that's when we see people getting, who've had a lot of trouble either trying naturally, or they've had multiple miscarriages or failed embryo transfers. Like, often there's this sweet spot that you can get to, and then that's when things work out.
Thank you. So we're going to close out soon. I just want to make one comment about the fact that it is not separate, right? Like, even the way I was phrasing the question, is there something you can do to improve ovarian reserve? Of course, that's like so typical of me, of a surgeon asking a question, how can we address this specific issue? My mom's gonna be happy to hear that, because like, she tells me, you can't eat cold stuff in the morning. I'm like, why? I don't understand. Like, I don't understand what you're talking about. It doesn't make any sense. But what I was gonna say is really that it doesn't happen in isolation, as you were mentioning, right? Fertility does not happen in isolation to the rest of your body, to the rest of your system, to the rest of your life. And I think we get super goal-oriented in this culture, in this society, and women are going, I need to have, how do I get pregnant? And I think one thing we want to tell you is that we want you to take care of yourself first, because you're going to be a mother and you are going to have to carry a baby, which my previous residency director called a parasite in your body. So it is a baby that you have to nurture in your body, right? So you have to be in a good place emotionally, physically. There's so much that women can put to the very last of like their own, on their priority list. Women often at the very bottom of your own priority list. So I guess I just wanted to tell everyone who's joining that it's really important to take care of yourselves. And then obviously this is a focus, and we understand that you are pursuing this, and we are going to help you get there as a team. And we are so glad to have this panel of doctors to help us take care of you. And we thank them so much, because these are all my colleagues who I just have so much admiration and respect for. Anyway, so thank you so much for joining us tonight. This will be, I think this will be posted on our website as well for those of you who have missed it, who want to watch it on video recording. Thank you so much, guys. Have a good night.
Thank you, everyone.
Thank you so much.
Thank you. Bye-bye.